Hello, everyone. I guess I'll start by introducing myself. I am Nathan Lamb. I'm a pharmacist at Boston Children's Hospital. My area of practice is neurology, or at least my primary area of practice. And I have been working with our neurology and our epilepsy group since completing my pediatric residency at Boston Children's in 2010. Today's lecture is antiepileptic drugs and febrile seizures. Really, the objectives, probably like most of you, when I was a student, I was not planning on going into a career in neurology, and I suspect most of you don't work in that area and may not be going into that area. So the objectives are really focused for, at least ideally, for someone who may encounter a patient on an antiepileptic drug, AED, or a patient with febrile seizures, and not necessarily trying to turn everyone into a specialist in AEDs. So the objectives are really to be able to list common side effects of antiepileptic drugs, identify severe and toxic side effects of AEDs, and then describe appropriate monitoring for AED therapy. And then finally, assess appropriate therapy for pediatric febrile seizures. So to get started, just a quick refresher: seizures, the definition: temporary disruption in brain function due to hypersynchronous excessive discharge of cortical neurons. So really, the clinical manifestations can be a number of different things, right? We think of the typical motor function, but there can be sensations or alertness or perception or autonomic function. The causes can be multifactorial, or several different causes for different patients: fever, meningitis, hypoglycemia, hyponatremia, or intoxication. The definition of epilepsy is essentially two or more unprovoked seizures. So it would be a seizure that wasn't provoked by things like hypoglycemia, hyponatremia. And then the definition of medically refractory epilepsy is failure of two or more appropriate medications to control seizures. So seizures, 1 to 2% of the population will suffer from epilepsy. It is one of the more common forms of neurologic disorders. It's following stroke. About 5% of children will experience a seizure, but only 50% of those patients will go on to have a second unprovoked event, and therefore having the diagnosis of epilepsy. Once a patient has a second unprovoked event, the risk of having subsequent unprovoked events is up to 80%. So then that's why that's the definition of epilepsy. And for almost all seizure types, that's the indication to start therapy, is once you have that diagnosis. So there are two different types of seizures, or a few different types of seizures. The typical classification is a partial seizure, or maybe the more common term is focal seizure. A simple partial seizure, the idea is it stays localized to one part of the brain. So that would generally mean you would not have impaired consciousness. And a complex partial seizure, by definition, the patient would have impaired consciousness, because it would start focally and then spread more generalized throughout the brain. A generalized seizure, by definition, starts in all areas of the brain, so the patient will have a loss of consciousness. And that includes a lot of common seizure types, what we think of generalized tonic-clonic, grand mal, absence, myoclonic, atonic, and infantile spasms are a few. So now we're kind of getting back to some of our chemistry or physiology, and we're going to be talking about kind of generation of seizure activity. But essentially, there's a generation of an action potential, and there's always a balance of excitatory inhibitory pathways in the CNS. The pathologic response is there's an abnormal, large, synchronous excitatory postsynaptic action potential is generated. So this means, you have this electroactivity that keeps perpetuating itself, and it's inappropriate. So you have activation of voltage-dependent sodium channels and calcium channels, and potentially this burst of action potential discharge. Sometimes there are even an epileptic focus or foci that are neurons that kind of act as a pacemaker. and this is the visual representation of what we just discussed. You have kind of your baseline action potential, and then there's a threshold for excitation, and once you reach that threshold, sodium channels rush into the cell, potassium channels leave the cell to start to counterbalance that, and then at some point you become refractory, potassium channels continue to leave the cell, and then you have a period where you're even hyperrefractory, and it takes some time to go back to equilibrium. So in a patient with epilepsy, this you don't have the same balance of kind of reaching equilibrium. So if you kind of look at it visually in the synapse, you can see the excitation pathway. Glutamate is the primary excitatory neurotransmitter, and that is stimulated by calcium into the presynaptic cleft and release of glutamate, and then you can see the glutamate binds to some sodium channels and calcium channels, and they're both voltage-gated channels and NMDA and non-MDA related channels. And the reason we're highlighting this is just we'll emphasize how some of the drugs work on the excitatory pathway and on some of these channels. And then the primary inhibitory pathway is the GABA pathway. So you can see that calcium also affects the release of GABA. GABA affects chloride influx into the cell, and that there's a GABA receptor there. And drugs affect the GABA inhibitory pathway in several different ways. So many AEDs, like we said, alter voltage-dependent ion channels. So many of them affect sodium channels. Common ones: phenytoin, carbamazepine, oxcarbazepine, and several others. A couple affect calcium channels, like ethosuximide or phenytoin. And then there are drugs that work on the glutamate and NMDA receptors, kind of a different aspect of the excitation pathway, like lamotrigine, topiramate. There are actually a few others on the market that probably work on that pathway now. And there's also other agents that augment the GABA pathway, things like phenobarbital, benzodiazepines, and then valproic acid and a few other medications that also work on that pathway. And then this is more graphically representation of that. You can see phenobarbital and benzodiazepine bind at different sites on GABA receptors, and vigabatrin, tiagabine, and gabapentin work on different parts of the GABA pathway to prevent breakdown or increase release or increase sensitivity. And then you can also see that many of these drugs work on the excitation pathway as well. You can see some blocking calcium channels, many blocking voltage-gated sodium channels, and then a few working on non-MDA and NMDA receptors. So really, like we said, one of the main things we're going to focus on is side effects and toxicity. If you think about the term side effect, it's really, there are dose-related side effects and there are some dose-independent toxicities. The older AEDs as a whole, are potentially dangerous class of medications. They require pretty careful monitoring to ensure safety. And the reason for that is often they have a narrow therapeutic range. The range that's toxic is very close to the range that is effective. They have several drug interactions compared to newer agents, and some of the toxicities can be quite severe. The newer agents in general are safer than traditional AEDs. They have wider therapeutic ranges. They generally have fewer drug interactions. They have more moderate side effects, and the toxicities are fewer and less severe generally. And we'll go through antiepileptics kind of chronologically to emphasize that point. One thing that we need to talk about in discussing antiepileptic drugs, that there is an FDA alert. It was released in 2008 for an increase of suicidal behavior. As you can see, the alert makes it sound like there's twice the risk of suicidal behavior. So that number can sound pretty scary, but the absolute risk is 0.22% of patients who are not taking antiepileptic drugs compared to 0.43% of patients who are taking antiepileptic drugs. So the risk is applied now, this warning is applied to all AEDs, but the relative risk, while it seems high, the absolute risk is very, very low, and the need to treat seizures far outweighs the risk here. So the important factor is really for potentially your older children or adolescents to at least consider counseling them or counseling the family, that if these thoughts or behaviors start to develop, that then you would potentially associate that with the medication and maybe need to make changes as appropriate. If you look at the timeline, you can see in the early 1900s, not very many medications were available, and really starting in the 70s, a couple more medications, and then in the 90s, we finally had a lot more medications that started to slowly come onto the market. And those are a lot of the medications we see very, very commonly today, things like lamotrigine, topiramate, levetiracetam, oxcarbazepine. And then even recently, we've had another surge, or it feels like a surge of new medications with rufinamide, lacosamide, vigabatrin, clobazam, and then now perampanel, esacarbazepine, and brivaracetam. So if we're starting kind of from one of the oldest drugs we have, 1912, phenobarbital became available. So its mechanism, it is a barbiturate. It binds to GABA receptors, so it works on the inhibitory pathway. And it does work on a different site than benzodiazepines. Its place in therapy, it is a relatively broad-spectrum antiepileptic drug. It's not indicated for absence. You'll see as we go through, absence has a few medications that are indicated. It can be used as monotherapy for tonic-clonic, partial neonatal, and febrile seizures. So it's a drug that works fairly well for several seizure types. Administration in neonates, it can be given as infrequently as daily, and most children are on twice-a-day dosing, and adults. Metabolism, it's metabolized hepatically, and like we said, the half-life can be extremely long in neonates, 500 hours. So then that kind of facilitates the once-daily dosing. One of the downfalls, despite being a fairly effective antiepileptic, is it is an inducer. So it induces several CYP enzymes hepatically. So then that causes interactions with many other medications and interactions with other antiepileptic drugs. It becomes even more complicated if there are agents that have a narrow therapeutic range, and now this is affecting that efficacy. So if you're on phenobarbital, probably the key point here is really to consult your provider or a pharmacist to assess for medication for all the other medications, either when you're adding or removing phenobarbital. So now here, what I really try to highlight, emphasize for common side effects, it's really sedation, psychomotor delay. Like we said, it works on the inhibition pathway. Really, the severe side effects of phenobarbital are potentially respiratory depression, hypotension, and myocardial suppression. This is really at high doses. So hypotension, potentially when a patient's being loaded for an initial treatment, and some of these other more severe respiratory depression or myocardial suppression would be for patients maybe in an ICU setting or very refractory or receiving extremely high doses at usually intravenous. One of the other consequences with the drug being an inducer is that it also can cause vitamin depletion. It's recommended that patients are having a diet that is adequate in all of these vitamins, or potentially taking a multivitamin to make sure they maintain sufficient amounts of these vitamins. Monitoring, you do monitor therapeutic concentrations. 15 to 40 is the usual range, and we say toxic greater than 40, but that just means more and more risk for things like sedation, respiratory depression, hypotension, and so on. Labs you need to monitor because it's hepatically metabolized, LFTs, and CBC. There is some risk for some WBC suppression. So the next medication was phenytoin, Dilantin. That was 1973. So this is, if you read the mechanism, it says it stabilized membrane via voltage-sensitive sodium channel. So here we're talking about the sodium channels, the excitatory pathway. Its place in therapy, it's a relatively broad spectrum AED. It's not indicated for absence, myoclonic jerks, or Lennox-Gastaut. So it does have a few exceptions where it will not be effective or potentially even exacerbate seizures. It can be used as monotherapy, and it's often used, or historically often used, for prophylaxis following head trauma. You see levetiracetam as a newer agent being used even more commonly now for prophylaxis for head trauma. Its administration, there are some challenges with administering phenytoin. We recommend to be consistent with one brand because it does have such a narrow therapeutic range. The suspension settles very easily, so we actually recommend that families shake the suspension for at least a minute prior to administer their doses in order to have a consistent dose every day and throughout the month and throughout the duration of that prescription. So we often try not to use suspension if possible. And the IV form of phenytoin has to be administered very slowly because it's a vascular irritant. Phosphenotoin is a medication that is phosphorylated, makes it much more water-soluble and less irritating to the veins, and that's the typical IV medication that's given for phenytoin, phosphenotoin. The metabolism, is hepatic, and it follows what's called nonlinear kinetics. So generally what that means is where, for most of us, no matter what dose we give, as we give a higher and higher dose, the body continues to clear the medication at the same rate. Like I still will clear half the drug every 8 hours, no matter how big the dose was. With phenytoin, as you get to higher and higher doses, your body seems to kind of max out at how fast it can clear the medication. So you could make a small dose increase and see a significant increase in your plasma concentration because of the nonlinear kinetics. So it makes it difficult to manage. You have to check concentrations frequently, and it's a little bit unpredictable. Interactions, it is also an inducer of CYP enzymes. So it's several drug interactions with other medications and several drug interactions with AEDs. Food, it's also absorption decreased with food or antacids. It also can't be given to a patient receiving continuous feeds because it significantly reduces absorption. As far as adverse effects, there are some dose-dependent adverse effects, things like drowsiness, ataxia, arrhythmias, nystagmus, mental status changes, and encephalopathy. So these are the types of things we think about as a narrow therapeutic drug. As you push that dose to the limit or maybe cross that threshold, patients may develop, cross into more and more mental status changes, like nystagmus is kind of one of the early signs, but then they'll go on to mental status changes and ultimately encephalopathy. There are some side effects that are not dose dependent. Things like hirsutism, gingival hyperplasia, potentially Stevens-Johnson syndrome, blood dyscrasias, or hepatitis. So there are risks with this medication even if the concentrations are controlled well. And again, this medication can cause vitamin depletion, and a patient should be on probably a vitamin D supplement plus a daily vitamin. So monitoring concentrations, a typical therapeutic concentration is 10 to 20. And because the drug is highly protein bound, you could also measure a free concentration, which would be the amount that's active in the body, and that's usually maybe a range of 1 to 2. Boston Children's, we typically say 0.6 to 1.8. So for this medication, you monitor CBC, LFTs, and albumin to help keep track of the protein binding. So you can see those first two medications work well for seizures, but they're not without their risk of drug interactions and toxicities. Ethosuximide, 1960, the brand name was Zerontin. Its mechanism of action is it increases seizure threshold by depressing action potential transmission. So a little bit more vague, but it definitely works on the excitatory pathway and kind of is an inhibitor along the excitatory pathway. The place in therapy for ethosuximide is really for absence. It has a few other indications, but absence is the biggest use that you'll see. It's not particularly effective for grand mal seizures and probably should not be used if the patient has multiple seizure types. What you'll see is the benefit here with ethosuximide, while it has that narrow range, when we get to drug interactions you'll see, and side effects, it has a much safer profile. It comes as liquid, and it also comes as capsules. If you had to, the capsules can be frozen and cut. I've tried this for a patient once, and it's not quite as easy as it sounds to freeze a capsule and cut a partial capsule, but we had to do it for a patient on the ketogenic diet. And potentially this suspension can be given rectally, but I've never seen a patient who required that. Metabolism, it is metabolized hepatically, so it might be affected by those other inducing agents that we talked about, but it doesn't have a strong effect on any other medication. Its half-life is 25 to 35 hours, so you can give it twice a day. And as far as interactions, other CNS depressants can also kind of exacerbate a CNS depression effect. And then, like I said, other drugs that affect CYP3A4 may decrease the concentrations for ethosuximide. So here, as we're talking about adverse effects, some of the common adverse effects, rather mild things: sedation, dizziness, rash, often nausea and vomiting with initiation. And severe, there is maybe a little bit higher risk of depression or mental status changes with ethosuximide compared to other antiepileptics, but this is still pretty rare. Monitoring, there is therapeutic monitoring. You can see the range is much wider than the first two agents we looked at, the toxic range being much higher than the typical therapeutic range. The monitoring is even more helpful if you have a patient who's on multiple agents that might be interacting. Primarily for maintenance monitoring, labs and concentrations are what you would need. So our next agent is diazepam. That was the next agent on the market. We'll kind of use this as an opportunity to discuss all benzodiazepines. Common ones: clobazam, clonazepam, clorazepate, not as common, diazepam, lorazepam, and midazolam. Essentially, all these agents bind to the GABA receptor in the brain, and they work on the inhibitory pathway. Almost all of these agents can be used as an initial medication for stopping seizures, and most of them can be used alone or in combination for almost all seizure types. Common side effects, now if we're really focused on all these meds, would be true. Sedation is the most common, and really severe would be respiratory depression. Often you don't see respiratory depression with just one agent, but potentially when you see a patient who's in status who you've given benzodiazepines or multiple doses of benzodiazepine and then multiple agents on top of that, will just continue to exacerbate the respiratory depression. Dosing, so if we focus on diazepam for dosing, especially Diastat being probably one of the most common medications we'll see in practice, hospital or ambulatory, it's interesting because the dose, milligram per kilogram, reduces as the patient gets older. So a 2 to 5-year-old, 0.5 mg per kg per dose, 6 to 11 down to 0.3, and then greater than 11.2 mg per kg per dose. If Diastat's not available, you could use the injection form, and this was much, much more common prior to diazepam, the Diastat, coming onto the market. Diazepam also has drug interactions. Interacts with phenytoin, carbamazepine, Depakote, and phenobarb. There are agents that can actually increase the effect of diazepam. They inhibit its clearance, things like cimetidine, erythromycin, because those are strong inhibitors. And you would not use this medication with ritonavir. Any HIV patient, you'd have to be pretty careful with your choice of antiepileptic drugs. And of course, if you're using sleep aids or other sedatives, it can really amplify the effect from diazepam or other benzodiazepines. Diazepam specifically, food interactions, grapefruit juice also increases the absorption. Next medication we'll discuss is carbamazepine, Tegretol. That was 1974. Its mechanism of action, it again works on sodium channels and just stabilizes the cell membrane. Its place in therapy primarily is used for partial onset seizures, but it can be used as monotherapy for either type. It can be used for other things too. things like neuralgias or bipolar disorder, so you may see it outside of epilepsy therapy. Administration. So the administration kind of changes depending on the type you're giving. So if you're using the immediate release, like the suspension, it has to be given 3 to 4 times a day. It can be used rectally. I again haven't had a patient where we've had to make a dilution and administer rectally. As you advance, if you use the Tegretol as the brand name for the extended release tablet and Carbitrol as the brand name for extended release capsule, you can get away with twice-a-day dosing. So a lot of patients will be on one of these 2 dosage forms. What's interesting about the tablet is that it is a wax matrix. So that means there are small holes in the tablet that release medication at different rates. So you can actually find remnants of the tablet of this wax matrix in the stool if the patient's taking the Tegretol XR. And the Carbitrol is a little less strange. It is a capsule that can be open and it can be sprinkled on soft food, and then what that provides is there are 3 different bead sizes, and so those beads will dissolve and be absorbed at different rates, so that helps support twice-a-day dosing. Metabolism, it's again metabolized hepatically. One of the really challenging things with carbamazepine is that it induces its own metabolism. So as you start a patient on a dose, the patient could respond nicely. You could check a concentration. They could be at a therapeutic concentration. But then as the induction sets in, maybe 1 week, maybe 2 weeks, maybe up to 28 days, that patient's concentration will drift down. So you have to constantly check concentrations to make sure you are achieving your therapeutic concentration. Drug interactions, again, because of this induction, there are several potentially dangerous interactions. Warfarin, other antiepileptics, other antifungals could also affect the metabolism of carbamazepine. Food interactions, again, grapefruit juice or alcohol. And test interactions could give a false positive for tricyclic antidepressants if you're doing a tox screen, and it may interfere with the pregnancy test. As far as adverse effects, common ones, a lot like we saw with phenytoin, ataxia, sedation. This could cause other things, nausea, vomiting, diplopia, an anticholinergic effect even. Things that are independent of concentration. Rash is common, especially severe rash, and it also can cause light sensitivity. Severe side effects can be leukopenia, aplastic anemia, hepatitis, and Stevens-Johnson syndrome. So you have to monitor a patient for CBC very carefully, monitor LFTs, and you have to monitor concentrations. So typical therapeutic concentrations are from 4 to 12, and you can see toxic greater than 15. So it doesn't take much going over the usual range to hit a toxic range either. So this is a drug that has, while very effective, especially for focal onset seizures, it has a narrow therapeutic range and several drug interactions and some potential toxic side effects. Now we're talking about valproic acid, brand name Depakote Depakine, that was made available in 1978. It has a kind of a unique mechanism. It enhances the activity of GABA, so it works on the inhibitory pathway, so it doesn't bind the same site as phenobarbital or benzodiazepines. And it may also have several other mechanisms of action that aren't as well understood. The nice part about valproic acid, it's probably the most broad antiepileptic drug that we have. It can be used as monotherapy for partial, generalized, myoclonic, mixed, even absence seizures. It can be used as monotherapy. And you see a lot of Depakote used in the community for things other than seizures as well. Bipolar disorder, even mood disorders, not as often for migraine prophylaxis. Administration, again, has several different dosage forms. It has a syrup, which is an immediate release that probably has to be given 3 times a day. It can be diluted and given rectally. Again, I haven't had to use that route for any patients. There's an enteric coated tablet and enteric coated capsules. The capsules can be opened and put on food. They're both considered delayed release, so they can be given twice a day. There's also a Depakote ER, which is an extended release, which is very easy to confuse with Depakote DR, delayed release. But the extended release can be given just once a day, and it only comes as a tablet. Its metabolism, it is metabolized hepatically. It's through CYP2C19, but it's also metabolized in the mitochondria, so it has multiple metabolic pathways. This drug, as far as interactions, it inhibits multiple metabolic pathways, so it has several drug interactions with drugs that can be potentially inhibited. It's not through the CYP pathway, but it's through several other pathways that metabolize medications. So basically, like we've said with all the inducers, basically when you start the medication or when you stop the medication, you need to reassess the medication list. Same with valproic acid. Whenever you start this medication and whenever you stop it, you really need to assess the medication list for drug interactions. Adverse effects. There are a lot of common adverse effects here. So it's a very potent med, but has a lot of adverse effects. GI discomfort is common. Weight gain is potential. Resting tremor is potential. It can cause sedation. It can cause increased blood sugar. Some patients will have alopecia. For some patients, that may be mitigated by the use of zinc, but not all. And then there are also potentially severe side effects. Things like hyperammonemia, liver failure, thrombocytopenia. Thrombocytopenia does seem to be dose dependent. And pancreatitis. Pancreatitis does not seem to be dependent on dose nor duration of therapy. One of the things you can do to help prevent liver failure and hyperammonemia is supplement a patient on carnitine. The highest risk groups of patients are probably patients with baseline mitochondrial disease. The drug is probably contraindicated in a patient like that. Patients on high dose valproic acid or patients less than 2 would be good candidates for carnitine supplementation. And that helps support the metabolism of Depakote. Monitoring, you should monitor therapeutic concentrations. Typical therapeutic concentrations are 50 to 100. We say that toxic is greater than 100, but that's probably more likely for things like sedation. There are indications where concentrations may be pushed aggressively and potentially above 100. So you can see it's a little bit wider therapeutic range, but it does have drug interactions. It does have some potential toxicities, but it's a very effective medication. So for the monitoring, you need to monitor LFTs, you need to monitor CBC, and you would monitor ammonia, but really, if the patient's experiencing mental status changes, it would be time to check ammonia. So the next medication, you can see the valproic acid was 1978, and now we're on to lamotrigine 1994. So it's quite a while before another drug entered the market. And you can see lamotrigine, similar mechanism of action to meds that were on the market. It alters sodium channel conduction, but also may affect the release of glutamate. Its place in therapy, it does seem to have a wide range of uses. It can be add-on therapy for partial seizures, generalized seizures, atonic, myoclonic, Lennox-Gastaut, and it can be used for absence. It's probably less effective than medications we've talked about, valproic acid and ethosuximide, but it will potentially treat absence. And you will see potentially a lot of use for lamotrigine for bipolar disease or other mood disorders. Administration, it comes as tablets, it comes as chew tablets, and it also comes as oral disintegrating tablets, so almost any dose can be made with a combination of these dosage forms. Metabolism, it is hepatically metabolized, but it's not by CYP enzymes. However, it is affected by the other antiepileptic drugs that we've discussed that are inducers and are inhibitors. So when you start lamotrigine, it's extremely important that you know which other medications the patient is on, because the dosing scheme will change dramatically depending on if you're on no other meds, if you're on an inducer, or if you're on an inhibitor. Adverse effects. So now we're looking at common adverse effects. Nausea, vomiting, dizziness is probably the most common thing I see, maybe some sedation. As you can see, these are much more mild and much more limited. Severe side effects. Life-threatening rash is the biggest side effect that you need to be aware of with lamotrigine, like Stevens-Johnson's rash. And it's very, very likely that it is titration dependent. So we have an extremely careful titration when we initiate patients. It takes 2 to 3 months to reach the full therapeutic dose because of the slow titration. But when we follow this titration, we almost never see a patient. In my practice, I've seen no patients who have developed a Stevens-Johnson's rash. A few patients have developed a mild rash, and we stop the medication immediately, and we have not retried the patient. Monitoring, you can monitor therapeutic concentrations, except there isn't a well-established therapeutic range. Patients can be therapeutic above or below this listed range. You can see it's a wide range, and there's not a strong association with toxicity. You can potentially, you have more of the dose-dependent side effects once you start going over 30 micrograms per ml. Again, you need to monitor the patient for rash, and you should monitor for LFTs because it's hepatically metabolized. So this is now, we're looking at newer AEDs, a safer profile and similar efficacy to older agents. You see, now the next agent was topiramate, 1997. It also had some new mechanisms of action. It may interact with sodium channels, it may potentiate GABA, and it may block glutamate, so work on both inhibitory and excitatory pathways. And it also is a weak carbonic anhydrase inhibitor. Its place in therapy, it's an add-on agent for partial or generalized tonic-clonic seizures, and you may see this used much more often as a medication for migraine headache prophylaxis. It can be given twice a day. There are now extended release formulations that could be given daily. Metabolism, it's minimally hepatically metabolized. So it's primarily renally cleared, which is nice because now this is one of the first agents that has fewer drug interactions. It will interact with something like acetazolamide, and some AEDs may decrease the efficacy, but it's not as clear or as strong as the other agents we've seen. Adverse effects, it does have a fair number of common side effects. It can cause cognitive impairment, things like word recall difficulties. So this can be a limiting factor, especially for adolescent patients and definitely for adults. They will self-identify that they're not able to remember things that they used to, or maybe students aren't testing as well as they had been before, aren't performing at the same level in school. And so topiramate is a common culprit for that and would have to be monitored. It can cause weight loss. Nystagmus, diplopia are much less common, and it can cause kidney stones. That's mostly related to metabolic acidosis as a consequence. And as you see here, decreased CO2 would be more common, and then the severe would be metabolic acidosis. So that is dose dependent. So as the patient gets titrated on a more and more aggressive dose, you need to keep an eye on the bicarb and potentially supplement so the patient doesn't become acidotic. Monitoring, again, there's a therapeutic range that's listed, but therapeutic concentrations are not well established. A patient could be therapeutic almost anywhere in that range. Labs, you should monitor renal function, and like we said, you should keep an eye on the bicarb. Levetiracetam, Keppra, probably one of the most common drugs that we use. Its mechanism of action is potentially unknown. There is like a vessel protein that is believed is the primary consequence of its action or primary mechanism of action. Its place in therapy, it can be used as monotherapy or adjunctive therapy, partial or generalized seizure types. and it's very often used as a first-line agent because of its safety profile. It can be given 2 times a day. It's generally recommended 2 times a day. Some of our patients, because of the half-life, really have seemed to benefit from dividing the dose into 3 times a day dosing. It's metabolized. This is the first agent that's not metabolized hepatically at all. It's metabolized by enzymatic hydrolysis, which is not a C/P pathway either, and then it's cleared renally. So very few drug-drug interactions. It's not really affected by other antiepileptics, pretty much other than the potential for increased sedation as you add more and more CNS depressants. And it doesn't really affect other AEDs either. Common reactions, I mean, it can cause drowsiness or sedation, but one of the most common reactions we see is it causes irritability or agitation. Adults are kind of able to describe this as maybe having a shorter temper or being more irritable, and children don't express it themselves as well, but family will recognize that they are much more irritable or much more aggressive. For some patients, this is a limiting factor for the agent. For many patients, we might try giving them pyridoxine to see if that will help with agitation. There's not strong evidence for that, except anecdotally for some families, they believe it really works. Severe side effect, maybe potentially psychosis. There are very, very few listed severe side effects, and they're all very rare. But irritability and agitation could advance to something like psychosis. I've seen one patient who was admitted with a psychotic episode after initiating levetiracetam that resolved after stopping the Keppra. So we really thought that that was related. Monitoring, again, there's a therapeutic range that's listed, but no evidence to associate either efficacy or toxicity in this range or outside of this range. So there are limited uses for therapeutic monitoring. So we've gone through a lot of drugs. Maybe it's time to think through just a quick case. If we had RT, 18-month-old female, history of generalized seizures, she's on phenobarbital, and her seizures are getting worse. Which medication may be the next most appropriate? So I think if we are focusing on her age and her seizure type, we're thinking about drugs that wouldn't interact with the phenobarbital and would work for generalized seizures. And so likely the answer here is levetiracetam. All right, moving on. Oxcarbazepine, trileptal, it was released in 2000. The mechanism of action is, again, it works a lot like carbamazepine. It stabilizes voltage-gated sodium channels. As you'll see there are a lot of benefits to oxcarbazepine compared to carbamazepine. They aren't the same drug. They are slightly different. They don't metabolize quite the same way. The place in therapy, it's often used as monotherapy for partial seizures. And like I said, because of the safety profile. And it can be used as an adjunctive agent for several other seizure types. Administration, it's given twice daily. There's a liquid and there's a tablet formulation. There is an extended release formulation on the market now. We don't see that used too often, but you could give it daily with the extended release. It is hepatically metabolized, and it's primarily an inducer. So it does have some drug interactions, but they are likely not as strong as the phenytoin and carbamazepine that we saw before. Interactions, so it does interact with other antiepileptic drugs because of that induction factor, and it does interact with birth control pills. Side effects, so now if we're looking at the common side effects, it can cause nausea, vomiting, drowsiness is probably the most common, ataxia is something I see commonly, especially upon initiation of therapy. If we start a little aggressively or a little too aggressively, patients may kind of present with ataxia or nystagmus, and usually just backing off on the titration or backing off on the dose and titrating more slowly will address that. Severe hyponatremia is a risk. It's unclear if that's dose dependent. Like we didn't focus on hyponatremia with carbamazepine, but we did focus on a lot of other severe things such as rash or agranulocytosis or things like that. And so you see that those are not as common with oxcarbazepine. If a patient has experienced rash with carbamazepine, there's a 25 to 30% cross-reactivity, so not ideal to switch to carbamazepine. So that's why, for the most part, we just start patients on oxcarbazepine because the risk is so much lower. Monitoring, again, you hear me say this a lot with these newer agents. This is a listed concentration range, but there's not strong evidence to support that this range will correlate with efficacy. You should monitor renal function and hepatic function because it's metabolized hepatically and cleared renally, and you do want to monitor sodium because this medication seems to have a higher risk of causing hyponatremia. So you can see very, very similar efficacy to carbamazepine, but much more mild side effect profile. Zonisamide, mechanism of action, if you are reading this carefully enough, it's going to sound a lot like topiramate. Stabilize membranes through inhibition of sodium and calcium channels, and again, a weak carbonic anhydrase inhibitor. It can be used as an add-on treatment for partial seizures. It can be given daily or twice a day. It has a very, very long half-life, so daily is appropriate for many patients. It is cleared hepatically and then also renally after that, or metabolized hepatically. Interactions, the inducers can decrease concentrations, but again, it's not as strong as a drug like lamotrigine. Lamotrigine may increase the concentration, but these are probably very mild, and you can titrate the dose based on clinical effect. Zonisamide is interesting because you cannot use the drug if they have a true sulfonamide allergy. That would exclude Bactrim as a sulfonamide antibacterial, which is a little bit different than a true sulfonamide. Adverse effects, you can see common side effects: psychomotor slowing, drowsiness, again, kidney stones, anorexia, tinnitus, or anhidrosis. Anhidrosis is kind of interesting, would be the lack of sweating or lack of appropriate sweating. So that could potentially lead to something like hyperthermia if a patient, if that went unrecognized, especially in a child, and was playing on a hot day and the family didn't recognize that the patient wasn't sweating appropriately. This does not seem to have the same cognitive effects as topiramate. I think there is still a risk, but it does not seem to be as pronounced or as common. And again, when we look at severe, we're looking at the metabolic acidosis risk. Monitoring, you can monitor concentrations, again, not well established with efficacy, and labs, because of the acidosis, you're monitoring sodium bicarb. You also need to monitor serum creatinine because the drug is renally cleared. Gabapentin. This agent came on the market in 2002. It was initially marketed or approved as an antiepileptic drug, but actually we see very low use in epilepsy and a very high use for neuropathic pain. Interestingly, thinking about the mechanism of action, despite the word GABA being in the name, it doesn't act directly on GABA receptors. Somehow it potentiates the GABA pathway and it works on the inhibitory pathway. It's pretty easy to give. Most patients can get by with 2 to 3 times a day dosing. You may need to increase the dosing to more times a day as you get to higher and higher doses, because you reach a threshold where the dose may have limited absorption with each dose that you give, so you may have to give it more times a day. Metabolism, it's entirely cleared renally, and it has very, very few interactions. Antacids may decrease the absorption. Side effects, drowsiness is probably one of the most common. It can cause a few other things. They're very likely dose-dependent, things like CNS depression. Monitoring, it's very easy to monitor. You can monitor renal function, and it's very unclear therapeutic concentrations. Rufinamide, we're getting into agents that are newer. Rufinamide is fairly new. I know it is in 2008, but we use a fair amount at Boston Children's, but I know when I talk about this drug to practitioners at other institutions, they are less familiar and more curious about rufinamide. Its mechanism of action it works on voltage-sensitive sodium channels. So it sounds a lot like we've been talking about with voltage-gated sodium channels, but this is, without going into too much detail, it's slightly different. So it has a little bit safer side effect profile, or at least that was the idea of developing the medication. Its primary indication was, or maybe the only FDA-approved indication, was adjunctive therapy for Lennox-Gastaut. But we use it for several other very similar seizure types in patients. The unique thing about administration with rufinamide is it really should be given with food. And all of the dosing is based on administration with food. So I word it this way: absorption's increased 60% with food, but if you think about the flip, it's decreased 60% if it's given on an empty stomach, which you may not get the full therapeutic effect. Metabolism, it is metabolized hepatically. It's not through CYP enzymes. However, it may be affected by valproate as an inhibitor. Inducers may reduce rufinamide. I haven't seen much of a clinical indication of this, but we have seen patients who've been on Depakote, and there is some evidence that patients on valproic acid, especially high doses of valproic acid, have higher concentrations of rufinamide, and the dose may need to be reduced. Adverse effects. So as we look at the common adverse effects, again, fairly short list here: dizziness, diplopia, really nausea and vomiting are the most common things we see. And that is mitigated by giving the medication with food, which we should be doing anyway, and also following a slower titration. Patients seem to, the GI seems to adjust to a slower titration, and patients have less vomiting. Severe side effect, it can decrease the QTc interval. So unlike many meds where we're thinking about prolonging QT, rufinamide can decrease QT. So you should get an ECG at baseline. If we're thinking about another case, TS is a 14-year-old, maintained on Depakote, rufinamide, and Keppra. And this patient has complex seizures. Now they start on lamotrigine. He's having trouble walking and significant dizziness. What's the most likely explanation? And, we didn't know options here. So really thinking about which medications, which ones can cause dizziness. We know lamotrigine. Dizziness is one of the most common side effects. And then if you're looking at things like drug interactions with the divalproex, rufinamide, or levetiracetam, the divalproex is an inhibitor. So it'd be very easy. Maybe they started on a dose that was too aggressive with lamotrigine, considering the other medications that the patient was on. Glucosamide, again, rather new medication, released in 2008. Its mechanism of action, like rufinamide, works on sodium channels, but again, it's a little bit of a twist on that concept. It enhances slow inactivation of voltage-gated sodium channels, so ideally maybe less of the sodium being released from the cell. And then, so maybe less of the side effects that are caused by affecting the rapid-acting sodium channels. Place in therapy, it's approved for partial onset seizures for patients greater than 17. I may have to update this. It may be down to 12 years now, but I might be getting that confused with another one of the new agents. Unapproved indications, we use it for a lot of patients, especially for refractory partial, potentially refractory generalized, and mixed onset seizures, but it really appears to be effective for partial seizures. And we've used it in patients probably as young as 6 months, and there are a few case reports in the literature using it in patients that young as well. And there are a lot of reasons that glucosamide is a very attractive option for young patients and patients with difficult seizure types, because it's very easy to administer. It's given without regards to meals. It's given twice a day. It's not highly hepatically metabolized. It is hepatically metabolized, so it may be affected by other antiepileptic drugs. I haven't seen that too often clinically, and there are really no major drug interactions. If we look at the side effect profile, 30% of patients will experience side effects, but very few of those patients have to discontinue the medication because of side effects. Dizziness is pretty common and headache is pretty common. Some patients have somnolence. And as far as QT, it does prolong QT and is likely dose dependent. So that would need to be monitored. Very rare would be something like face swelling, angioedema, or hypersensitivity. So for monitoring, it's recommended to get an EKG at baseline and at steady state. And then you would get periodic LFTs and serum creatinine because of the metabolism and clearance. So as you can see, this is a fairly safe drug to give, very low side effect profile, very few drug interactions, and pretty attractive alternative to a lot of the medications that were on the market prior to this point. If we're looking at a few of the other newer antiepileptic drugs, we won't go into too much detail with all of these. Some of them are becoming much more common in use. Vigabatrin, the brand name is Febrile, there are now generics. Its primary use is infantile spasm, but it can also be used for refractory complex partial seizures. It's only available through a restricted access program. The program has been actually renamed to Vigabatrin REMS instead of Share, mostly because the major side effect is bilateral concentric visual field constriction. So patients essentially could suffer vision loss. So there are requirements that patients need to be monitored every 3 months and at baseline for to have visual exams to make sure the patient isn't experiencing any vision loss. Because if they were, the patient would need to be switched to another agent. Perampanel is fairly new. This is the agent I was thinking of. Perampanel is for patients greater than 12, and lacosamide is still greater than 17. It does have a black box warning for aggression, anger, and even potentially homicidal thoughts, which is kind of unique. We talked about suicidal thoughts at the beginning, but this actually includes potentially very aggressive behaviors. But it has a unique mechanism of action, fairly safe profile, and we are seeing more and more use of perampanel. Eslicarbazepine, it was approved in 2003, and it actually will be completely removed from the market this year. So it had quite a lot of side effects and quite a lot of toxicities and a very narrow therapeutic range. So that had been voluntarily removed from the market. And brivaracetam, we're seeing much more use of this. It has a very similar mechanism as levetiracetam, currently only approved in patients greater than 16, but we have seen a small amount of use in some of our patients. So general things to consider with AEDs, that concludes the medication by medication portion of the antiepileptic drug section. Laboratory monitoring is important, especially for drugs that have potentially severe toxicities, and we'll have to monitor patients for that. Many patient-specific factors will guide therapy. Potential side effect, potential toxicities, past efficacy of past medications will really guide kind of which medication a patient ends up on. So often it's not my role as the pharmacist to be choosing the medication. That's, an epileptologist or a neurologist, but we are following up on all of the things like drug interactions and safety monitoring and all of those things. Most AEDs have drug interactions, and it's a class of medications that were kind of a red flag for me. If a patient's on an antiepileptic drug, I'm thinking, what are the other meds? Are there any drug interactions? Of course, never abruptly discontinue an antiepileptic medication. The only exception would be if the patient's having an allergic reaction or a life-threatening reaction, and then they would have to be started on another therapy immediately to make sure that they don't have refractory seizures or rebound seizures from the discontinuation. And then one of the big challenges that we have with antiepileptic drugs, as we talked about, there are oral disintegrating, and there are tablets, and there are delayed release and extended release, and there are liquids. So very easy to have confusion with dosage form. So as we are patients are coming into our system, we're taking medication histories, they may not express these things as accurately as we need them to, or and if we don't take the time to kind of really focus on those details. We've done it at our hospital, and I'm sure it happens everywhere, where they can get confused between extended release, delayed release dosage forms for patients. So it's really just to highlight that that's a consideration when thinking about patients on AEDs. Therapeutic drug monitoring, I'll touch on this just fairly quickly, mostly because I see it's something that is used very, very commonly with antiepileptics. And as you saw with many of the newer antiepileptics, there's not as much information for the therapeutic range. So there is a guideline. It was issued by the International League Against Epilepsy, ILEA. And they kind of outlined indications for therapeutic drug monitoring. So one is to establish an individual therapeutic concentration. This would mean the patient's been taking a steady dose of medication, they're at steady state, and they've been controlled on their medication. And you could check at 2 points in time what their concentration is, what their trough would be. And then you could say, you know what, for this patient, this is the concentration that controls their seizures. You can use it to aid in the diagnosis of clinical toxicity. So if there's suspicion of toxicity, checking a concentration would be appropriate. To assess compliance, especially if a patient's having breakthrough seizures. So when a patient maybe arrives in an emergency department or into a clinic and there's a question of compliance, or there's breakthrough seizures, it'd be reasonable to check a concentration. This becomes even more helpful if we have established an individual therapeutic concentration. And then, of course, in case of increased pharmacokinetic variability, the drugs like, that does say children. Most children have predictable kinetics. Pregnancy is a time when kinetics may be unpredictable, or disease-related concerns. If you have hepatic dysfunction or renal dysfunction, you may have unpredictable kinetics and may need to use therapeutic monitoring to guide your dosing. And then antiepileptics with dose-dependent pharmacokinetics, like we talked about phenytoin, as you get to higher doses, the drug is cleared more and more slowly. Carbamazepine, a drug that induces its own metabolism, so it kind of changes over time. So those medications would need routine therapeutic drug monitoring. So that concludes our medication by medication kind of a review of antiepileptic drugs. The next section we'll go through is febrile seizures. So it's an area that I think is encountered by a lot more practitioners and a lot more parents because it is fairly common. So we'll start with talking about fever. We start with fever phobia only because clearly febrile seizures are a risk of fever, but there is a lot of anxiety around caring for a patient that has a fever. The definition of fever is abnormally high temperature greater than 38 degrees. And of course, we describe it this way. It's a symptom. It's not a diagnosis. So febrile seizures. The definition of febrile seizure is it should be accompanied by a fever greater than 38 degrees. The patient should not have a CNS infection because that would be meningitis, and this would be a whole nother cause of the seizure. And the age range is from 6 months to 60 months. I mean, the literature expresses it this way, 6 to 60 months, but it's really from 6 months to 5 years. So the key differentiation here between simple febrile seizures, and complex febrile seizures. A simple seizure lasts less than 15 minutes, and it does not recur within the first 24 hours. And so you'll see a lot of our recommendations a lot of the recommendations and guidelines focus on the difference between a simple seizure and the complex febrile seizure. Up to 10% or maybe around 10% of febrile seizures will be complex. My work in the hospital, we end up seeing more of the complex patients, the ones that have not resolved, so that led to an admission to the hospital. If the seizure has a focal component, right, it started on one side of the body and progress to the other side of the body, anything that had a focal component to the seizure, this now falls into the category of a complex febrile seizure. If the seizure is prolonged, greater than a 15-minute seizure, or reoccurring within the first 24 hours, all of those, any one of those, would put the patient into the category of a complex febrile seizure. So, the presentation. Usually the seizure occurs, the initial seizure occurs around the time that the temperature is rising the most rapidly. You don't always catch the temperature at that time, and especially if the patient has an illness and then presents to a medical facility, there may be a gap in that time and you aren't, or maybe pre-treated, so you don't always capture the fever. But generally that first seizure is as the temperature is rising. The presentation is actually, there's nothing unique about a febrile seizure presentation. It really looks like a tonic-clonic seizure. It's loss of consciousness, apnea, incontinence, rhythmic jerking, and almost always followed by a postictal phase of confusion and sedation. Can last seconds or it can last minutes for some patients, or longer. The incidence. So 2 to 5% of children will have a febrile seizure in their lifetime. If you've had a febrile seizure, there's a small increased risk of epilepsy. We said maybe 2% of patients will have epilepsy, and now this is maybe a 5% risk of epilepsy. These numbers, depending on which study you read, are a little bit different. But in general, just because a patient's had a febrile seizure, your risk of epilepsy has not been increased very much. And there's really no change in risk of developmental delay. However, the one thing that are at risk for once a patient has had a febrile seizure is you're at risk for future febrile seizures. 25 to 30% that might be on the higher end of the risk. Risk is higher if you were less than 1 year, if the seizure was complex, if the fever was very short but the patient had a seizure, or if the temperature was low, right? Short fever or low temperature, or if there's a family history, your risk is higher. If the seizure does recur, most of these patients will recur even within 1 year of that first febrile seizure. And then here's more of a breakdown of risk factors, and they're additive. So you would add each of these risk factors up. So even something like being in daycare increases your risk. So you can see absence of risk factors, it may only be 2.2% for recurrence. But if you're relative, or if you're very other factors here too. So evaluation. The American Academy of Pediatrics in 2011 came up with their guideline essentially for how to evaluate a patient who presents with a febrile seizure. So even an EEG is not indicated for a neurologically healthy patient, especially for a simple febrile seizure. A Chem-10 should not be performed. Neuroimaging is unnecessary. And even lumbar puncture, there are only few indications for lumbar puncture if there are signs and symptoms of meningitis, if the patient's unimmunized, or an unknown immunization history, or if the patient's pre-treated with antibiotics, because then it's going to be a cloudy picture for infection or meningitis infection. So really, the initial assessment, especially for a simple febrile seizure, would not require any of these invasive or minorly invasive evaluations. Treatment. Now this is the tough part. NIH, their recommendations for treatment, they should treat a focal or a prolonged seizure, right? So both of those would fall into the complex. You would treat a patient who has a potential neurologic abnormality, potentially if there's a family history, right? If there's a sibling that has a history of epilepsy, you may start with treatment. If the patient's less than 1 year, you would start with treatment, but that is really only if the benefits outweigh the risks. And, or potentially if the patient had multiple febrile seizures in the first 24 hours. So again, a complex febrile seizure, you may consider initiating therapy. The American Academy of Pediatrics breaks it down that you provide chronic antiepileptic therapy for, chronic antiepileptic therapy for simple febrile seizures is not recommended, right? Even diazepam would only be recommended for a particularly anxious patient. So this is really focused on simple febrile seizures, that they would not require chronic therapy, and they would not require diazepam, a diastat, unless the family was really anxious about the presentation of seizure, and then you would educate them about how to administer diastat. And we'll talk more about the indications for therapy and the risk and benefit of therapy. So if we kind of break it down into a case to kind of look at what we talked about so far, 3-year-old girl, whole body convulsions, last 5 to 10 minutes in the setting of an URI. In the ED, you didn't have a fever, but the patient had one more event in the ED lasting 5 minutes, but did not require intervention. So now really the question is, or a question that may be asked, is how to classify this febrile seizure. Is it complex or is it partial? So if you look at the 3 factors, generalized, so it does seem generalized, so that would put it into simple. It did resolve within less than 15 minutes, so that would make it simple. But the fact that it reoccurred within the first 24 hours, even though it was self-resolved, would now technically make it a complex. And then the question, should the patient initiate treatment? In general, it's going to be risk-benefit. Likely this patient does not require chronic therapy. Treatment options. So we need to talk about antipyretics. This is always a sticking point, and this is why we talk about it and we emphasize it as much as we can. Things like Tylenol and ibuprofen. Of course, aspirin should be avoided because of the theoretical risk of Reye syndrome. And then we'll talk about antiepileptics, benzodiazepines like diazepam, phenobarbital, primidone. It works basically like phenobarbital. We don't really use primidone. And then valproic acid. So antipyretics. Antipyretics are ineffective without concomitant antiepileptic drugs. So kind of what this phrase is meaning is antipyretics, drugs that treat fever, are not going to reduce your risk of having seizures. Even though that initial seizure was likely caused by the rise in temperature, subsequent seizures, at least all of the evidence shows that subsequent seizures happen whether or not fever is controlled. So there's a study, essentially, Outret et al. Basically showed no benefit of Tylenol versus placebo for preventing febrile seizures. 1995, they used ibuprofen. They were able to show that there was a significant decrease in temperature, but there was no reduction in febrile seizures. And then they kind of had a follow-up in 1998. They did have a trend towards fewer febrile seizures using ibuprofen compared to placebo. And it's interesting because they did use a low dose. They used 5 mg per kg, and we often use the 10 mg per kg. But this data has never been replicated. No one's ever been able to replicate this data to show that treating fever would prevent future febrile seizures. We don't have an opportunity for question and answer, and this is a question that almost always comes up at the end of class. Why is this, right? The seizure is caused by fever. If I treat the fever, shouldn't I prevent seizures? And as much as that principle makes sense, or as much as we've maybe even seen someone prescribe this therapy to a patient or recommend this therapy to a patient, the evidence shows even if you control the fever, the patients have pretty much the same risk of those seizures reoccurring. So that's a key point, that treating the even if you successfully treat fever, it doesn't mean that you've reduced your risk of the fever recurring. Does this mean we shouldn't treat fever? Of course we should. We should try to make our patients comfortable, of course. But that doesn't mean that we will prevent seizures, unfortunately. So, and then the AAP has a statement in 2008, essentially antipyretics are ineffective to prevent recurrence of seizures. But they will improve comfort. They will not prevent seizures. They're not emergent medications, and the take-home point, and parents and caregivers can of course use these agents, but they're for comfort. So next, focus on the AEDs, their efficacy. So the drugs that really have the strongest evidence, phenobarbital, primidone, valproic acid, they really have proven their efficacy. Phenytoin and carbamazepine have not. And diazepam has also been proven efficacious. One of the ways that diazepam is used is as like a short-term prophylactic agent. It showed that there's a 44% reduction in seizure recurrence. So the way this would be done is if you have a patient that has a febrile seizure or illness, either way, maybe they have a history of febrile seizures, and throughout the course of illness, you would put the patient on diazepam. So they wouldn't be on a chronic therapy, but it would be a short-term therapy, kind of an empiric or prophylactic therapy. And they would be on 0.3 milligrams per kilogram per dose, so 1 milligram per kilogram per day, divided every 8 hours. And you would give it for the duration of the illness. And so this would be a way to potentially treat a patient that has a high risk of recurrence of febrile seizures. And you would be able to do that just over a short term, not chronic daily therapy. Now, if you're looking at efficacy, this is more acute. If you're looking at diazepam for acutely stopping the febrile seizure, 81% of patients, the medication worked acutely, but 31% had recurrence. And intravenous diazepam, basically 100% of patients were able to break the seizure, but then up to 60% had recurrence. And that's likely because of the way IV diazepam redistributes quickly. Phenobarbital. Now this would be considered either acute, or this would be for chronic daily therapy. You could give a load of 15 milligrams per kilogram. You want to get the serum concentrations up to 15 milligrams per liter. And now you could consider continuing this therapy for 6 months to a year. So this would be an example of giving chronic daily therapy. So in the beginning, we talked about patients that have had complex seizures, had risk factors for recurrence. Maybe the seizure was very severe. Maybe the patient ended up in an ICU, and so the risk of that seizure recurring is high, or the consequence if it occurs is severe. You may consider something like daily therapy. We had, of course, talked about a lot of the side effects of phenobarbital, but there's also a potential effect on long-term cognition, especially the younger the patient is, to go on maintenance phenobarbital. It's a medication that we try not to start on patients chronically if we don't have to. And of course, over time, the evidence is that this usually leads to a high rate of noncompliance because the risk is only at limited points in time. Other antiepileptics. So valproic acid would work. Of course, we talked about the risk factor of hepatic encephalopathy in patients less than 2. So we would try not to use it in that age group. And you do need to have a fairly healthy concentration, greater than 50. And we talked about there are a lot of potential side effects with valproic acid. LFTs, thrombocytopenia, CNS effects. We talked about other things, alopecia, tremor. And then primidone, that's metabolized to phenobarbital. So it has all of those same consequences. If you look at the efficacy, so you can see risk of recurrence is fairly low when you've put a patient on valproic acid, phenobarb, or primidone. You have to be on pretty healthy doses of these. Have to have pretty healthy troughs of these. And then this is more of just a visual breakdown of the side effects like we had talked about. Valproic acid, hepatotoxicity, weight gain, JAPSET, pancreatitis, alopecia, thrombocytopenia. And phenobarbital, really the thing that I think is one of the biggest consequences long-term is the potential for intellectual impairment. So this is what we've kind of been alluding to the whole time, the risk of therapy versus the risk of seizure. And you have to weigh that risk for patients who have had a complex febrile seizure. So the risk of therapy, systemic toxicities, some of the things like rash that are idiosyncratic, things that are dose-related, or even some of those chronic effects like development, like behavioral effects of development, or even cognitive impairment. There are also psychosocial consequences, of taking a daily medication, or even having the label of, chronic illness. And economic, these medications that be purchased by the family, they'll often require lab tests plus physician follow-ups to make sure they're monitored and administered safely. Now, the risk may be outweighed by the benefit for some patients, especially if the seizure causes something like physical injury, fall. If the patient went into status epilepticus, they ended in an ICU. Maybe the psychosocial risk of seizures, the restriction on activity if these happen routinely every time the patient is ill. There's a social stigma of having a seizure, or even family fear or patient fear of subsequent seizures. So all of these factors have to be taken into consideration when considering the risk and benefit of starting especially a chronic medication, a chronic AED for a patient with complex febrile seizures. So this is kind of exactly what we said. American Academy of Pediatrics, their 2008 consensus statement is that neither continuous or intermittent short-term anticonvulsants are recommended for children with one or more simple febrile. And then, again, no studies have demonstrated that antipyretics reduce the recurrence of simple febrile seizures. So we think about a case, 4-year-old, admitted to the hospital, they had a febrile seizure. They think they've had an ear infection. This is our same patient. The movements were similar as the first time. They lasted for less than 5 minutes. But the family also, they thought he was turning blue. In the O2, in the ED, when they first got here with the O2 stat, 92%. So now the question is, now at this point, should we initiate an AED? And so again, the question is really, this patient has gotten sick again. They've developed febrile seizures with this illness again. It's scary enough that they ended up in the ED, especially because of this potential desaturation. Do you think, do we consider treating this patient on a short term every time that they're sick? The family, if they get an ear infection, you go to the pharmacy, fill your Dazpam prescription, you give them Dazepam for that week and a half? Or do you say this patient really now falls into a category where they should get a daily medication for the next 6 months or the next year? And you really have to consider the risks and benefits. These are the references. Thank you for listening.